Factor 11. Neurodevelopmental disorders are a group of conditions generally noted with an onset in the development period with manifestations appearing during childhood or adolescence. These children may be bullied. If they are, encourage them to talk about how they feel due to the emotional pain bullying can cause. Sharing feelings provides the nurse with a chance to further assess the situation and provide support to the victim. Validate the child for reporting the bullying. Make sure when discussing mental illnesses that you use current terminology. Dated terminology contributes to stigma and misconceptions. So 20% of the children and adolescents in the U.S. suffer from a major mental illness that causes significant impairment. Does this surprise you? There are lots of barriers to assessing, diagnosing, and treating younger people. This can include delaying treatment due to a wait-and-see approach, lack of consensus in screening children, lack of coordination among multiple systems, lack of community-based resources, and long wait lists for services. Also a lack of mental health professionals, and cost or inadequate reimbursement to the families. So let's talk about risk factors. Biologically, genetics, heredity factors play a huge part. Neurobiological, changes in the brain during childhood and adolescence contribute to emotional and behavioral control. Early adolescence is typically characterized by low emotional regulation and intolerance for frustration. Emotional and behavioral control usually increases over the course of adolescence. Now, cognitive, temperament. Characteristics that are present in infancy can include their mood, attitude, and behavior of the child. It also includes how the child copes with their environment. If there is incongruence between parent and child temperament and the caregiver is unable to respond positively to the child, there is a risk of insecure attachment, developmental problems, and future mental disorders. Now, resilience. This is the process to adapt and recover quickly from a difficulty in life. It is influenced by self-concept, future expectations, social competence, problem-solving skills, family, school, and community. There are several points here that talk about resilience on page 170. Now, the resilient child has the following characteristics, and it's 1 through 6 here. Adaptability to changes in the environment, ability to form nurturing relationships with other adults when the parent is not available, ability to distance themselves from emotional chaos, social intelligence, good problem-solving skills, and the ability to perceive a long-term future. Now, environmental factors. Remember we talked about ACEs previously. Trauma is one of the strongest environmental factors associated with mental illness in children and extending into adulthood. Abuse also occurs, which can be in the form of neglect, which is the most prevalent type of abuse in the U.S., or sexual abuse, and that can be both of boys and girls. These risk factors include severe marital discord, low socioeconomic status, large families and overcrowding, parental criminality, maternal psychiatric disorders, and foster care placement. Trauma in childhood is strongly associated with adult dysfunction. All healthcare providers, including nurses, are required to report suspected abuse of a minor child to the local child protective services. And then culture. Consider the patient's ethnicity, worldview, religion, and socioeconomics. So assessment of children and adolescents is very similar to what we have already discussed with the nursing process, but it does have a few differences. In all cases, physical examination is part of a complete assessment for children and adolescents with serious mental problems who require hospitalization. Now, data collection. This includes observing, interviewing, and interacting with the child or adolescents. This is where you build trust and rapport. You may do this with therapeutic games, drawings, or even puppets could be incorporated. The initial interview is key to observing interactions among the child, caregiver, and siblings if they're available. And this is also, the initial interview is key to building that trust and building rapport. Now, the mental status examination must be adapted to the child's developmental level, cognitive abilities, and verbal skills. It helps identify problems the child may have with thinking, feeling, or behaving. And then the developmental assessment. This determination of milestones the child has met. The maturity level of the child can also be determined during this assessment. The Denver 2 developmental screening test is a tool used to compare the performance of a child on certain tasks with others of the same age. These areas of examination include social personal, fine motor function, language, and gross motor function. A developmental assessment will look at milestones such as the age a child starts walking, talking, or toilet training. A child or adolescent who does not have a psychiatric disorder matures with only minor regressions, coping with stressors, and developmental tasks of life. Box 11.2 on page 172 gives you the characteristics of a mentally healthy child or adolescent. Remember that stress-related behaviors are minor regressions, so maybe they go back to bedwetting, may be managed by working with the parents. So general interventions for children and adolescents, there are behavioral interventions, and using a reward system can be helpful with children and adolescents to help reduce maladaptive behaviors. Play therapy. Play is the work of the child. Play therapy can help the child express their thoughts and feelings in ways they may not be able to verbalize. So trauma is often stuck in the nonverbal parts of the brain, so the amygdala, thalamus, hippocampus, and brainstem. So playing out memories can help move these children to verbal frontal lobes. Bibliotherapy uses books or stories to help the child learn coping skills or express their feelings. When children listen to or read a story, they unconsciously identify with the characters and they experience a catharsis of feelings. Expressive arts therapy is a nonverbal way for a child to express their feelings or emotions. Children who have experienced trauma will often show the traumatic event in their drawing when asked to draw whatever they want to. Journaling is very effective, especially for adolescents. Music therapy. Think about how a song can bring forth emotion in you. So music can aid in creativity of the child. Music therapy is a non-threatening approach that engages multiple senses. Family interventions. So you may need counseling for the entire family because this can be crucial for effective treatment and improvement because the family is the foundation of the child's life. Teamwork and safety. Safety based on developmental levels and ensuring that all involved in care are up to date with the treatment plan. And then disruptive behavior management. Remember that the least restrictive method is always used first. This can include timeout, a quiet room, and seclusion and restraints. This principle requires that you use more restrictive interventions only after attempting less restrictive interventions that have been unsuccessful to manage the behavior. Less restrictive interventions include discussion, so asking the patient if they would like to talk about their anger, offering medication to help them gain control, and suggesting a timeout. This could be to their room or another quiet area. Finally, as a last resort, seclusion or restraint may be considered. In general, seclusion is viewed as less restrictive than restraint, where all movement would be constrained. So let's talk a bit about seclusion and restraint. Evidence suggests that both seclusion and restraint are psychologically harmful and can be physically dangerous. The registered nurse assigned to the patient is often the one to make the decision to restrain or seclude a child. A physician, nurse practitioner, or other advanced level practitioner must authorize this action according to facility policy and state regulation. The patient's family should be notified of any incident of seclusion or restraint. Patients in seclusion or restraints must be monitored constantly and not be left alone. Children are released as soon as they are no longer dangerous. Once the child is calm, the staff should include the child in a debriefing and discuss the events leading up to and including the restrictive interventions with the patient. Debriefing provides an opportunity for staff members to discuss the event and explore ways it may have been prevented, evaluate their own emotional responses, and review the plan of care, but also enhance their clinical skills. So treatment modalities, biological treatments, a multimodal approach is best with a combination of pharmacotherapy and another form of treatment, such as psychological therapies or group therapies. So psychological therapy, CBT, cognitive behavioral therapy, is learning to replace negative thoughts with realistic and positive thoughts. Group therapy are effective for dealing with specific issues and is different according to the child's age. So groups are effective when dealing with specific issues in a child's life, such as bereavement, physical abuse, or chronic illnesses such as juvenile diabetes. In your younger children, use play time during group therapy. In your grade school children, you want to combine play therapy and talk therapy. And in your adolescents, your focus is to help them learn skills and identify their emotions. So communication disorders. So now we will discuss specific disorders that are seen in children and adolescents. The etiology is often unknown, but comorbidities include hearing impairment, intellectual disabilities, developmental disabilities, autism spectrum disorder, ADHD, traumatic brain injury, and psychological or emotional disorders. So the first one we'll kind of dig into are language disorders. These are difficulties in attaining and using language due to deficits in production or comprehension of language. And this tends to show up prior to the age of 3. Now there's expressive language disorder. And this is challenges with forming sentences and using appropriate words and body gestures to communicate ideas. These people have difficulty communicating thoughts, concepts, and ideas as well as relating to others. Receptive language disorder challenges with understanding and processing verbal and nonverbal information from others. This is having difficulty comprehending what others are saying as well as applying information and following instructions. And these children have a poor prognosis. You also have speech sound disorders. This is where the child has difficulty making sounds. They usually respond well to treatment. Children may have trouble making certain sounds, so saying no for snow or wabbit for rabbit as an example. Speech sound disorders result in problems with social participation, academic achievement, and occupational performance. And then there's child onset fluency disorder. This is also known as stuttering. It's usually seen with hesitation or repetition. There is a good prognosis with most children recovering completely, and there is a higher incidence of this in boys. And then social communication disorder. This is difficulty using verbal and nonverbal means for interacting socially with others. They also have difficulty with written communication. Now, to diagnose with social communication disorder, you must first rule out autism spectrum disorder before you make this diagnosis. And note that the Disabilities Education Act provides for early intervention services in every state for toddlers up to age 3. Special education and services are also available for children or for people ages 3 to 21. Typically, the first step in the plan is a hearing test, followed by involvement with a speech or language therapist. So moving on to motor disorders. Developmental coordination disorder. This is a lack of appropriate motor skills and coordination below the child's developmental age. It will usually just be displayed as a it will usually display as delayed sitting or delayed walking, difficulty jumping, or performing fine motor skills such as tying their shoes. And this is going to be treated with physical and or occupational therapy. Now, developmental coordination disorder is based on number 1, impairments in motor skill development, number 2, coordination below the child's developmental age, and number 3, problems interfering with academic achievement or activities of daily living. Symptoms include delayed sitting or walking or difficulty jumping or performing those tasks that I mentioned, such as tying their shoelaces. Now, serious impairments in skills development or coordination are usually obvious. Less severe impairments may be less noticeable. They may be identified by the child's avoidance of certain tasks or certain activities. These children typically make comments like, "I hate to draw," or "I don't want to play kickball." Early diagnosis, treatment, and education are essential to prevent frustration and unnecessary problems in their adult life. Stereotypic movement disorder. These are repetitive, non-purposeful movements for 4 weeks or longer. These include rocking back and forth, nail biting, grinding teeth. They are more common in boys, but when you assess this, you should also assess their intellectual ability. The focus on them is safety, and you can treat with habit reversal techniques. Behavioral therapy includes habit reversal techniques such as folding the arms when the urge to hand wave begins. Naltrexone, which is an opioid receptor antagonist, may actually block euphoric responses from these behaviors, thereby reducing their occurrence. Tic disorders. These are movement disorders that are characterized by fast, unanticipated, non-rhythmic movements or vocalizations. Motor can include shaking, copying others' movements, obscene gestures, or blinking. Vocal can include throat clearing, echolalia, palia, which is repeating oneself, or copraxia, which is using curse words. But it's not like the movies. Copraxia actually occurs in less than 10% of cases. Now, tic disorders usually occur before 18 years old, and it's most commonly seen between 4 to 6 years old. You have provisional tic disorders. These are one or more motor and or vocal tics that have occurred for less than 1 year prior to the age of 18. Persistent, these are chronic. It is single or multiple motor and vocal tics must be present for 1 year, also prior to age 18. And then Tourette's disorder, which is what most of you have heard of. It is the most severe tic disorder. There are multiple motor tics and a vocal tic. It must persist for 1 year, and it must be diagnosed prior to age 18. It must also occur several times a day, almost every day, and not be the cause of medication for diagnosis. So Tourette's disorder often coexists with depression, obsessive compulsive disorder, and anxiety. Approximately 63% of those with Tourette's have also been diagnosed with ADHD. Symptoms tend to peak in early adolescence and diminish into adulthood. A child or adolescent with tics may have low self-esteem as a result of feeling ashamed, self-conscious, and rejected by peers, and may severely limit their public appearance for fear of displaying their tics. Behavioral techniques can reduce tic expression. They are referred to as habit reversal, and the most promising form is called Comprehensive Behavior Intervention for Tics, CBIT. It works by helping the patient become aware of the building up of a tic urge and then using a muscular response in competition to or incompatible with the tic. So the etiology of motor disorders. Developmental coordination disorder is usually has a low birth weight. The baby's usually premature. There's probably a family history of this, and there may be prenatal exposure to drugs or alcohol, and the prevalence is about 10%. Tourette syndrome tends to be inherited, and it can be related to maternal stress. Now, comorbidities of developmental coordination disorder can be learning disorders, ADHD, psychological or behavioral issues, deficient social skills, as well as depression and anxiety. And comorbidities of Tourette's tend to be ADHD, depression, and OCD, which is obsessive compulsive disorder. More than 85% of patients with Tourette's has at least one psychiatric comorbidity. So how do we treat tic disorders? So we've already mentioned the CBIT, Comprehensive Behavior Intervention for Tics, which helps the patient become aware of the beginning of a tic and then use a muscular response that counteracts it. Medications. You have your antipsychotics, such as Haldol and Orap, as well as second generation, such as Abilify. Risperdal is also used off-label for tic disorders since it has not been approved by the FDA. That's why it would be off-label. You also have alpha-2 adrenergic agonists, such as guanfacine and clonidine. These are both effective. Botox has also been used to calm muscles associated with tics. And then deep brain stimulation, DBS. This is used after failure or more conservative treatments have not worked. This is where electrical impulses are delivered through small wires that are connected to the brain. Learning disorders. A specific learning disorder is diagnosed when a child demonstrates persistent difficulty in reading, which is dyslexia, math, which is dyscalculia, and or written expression, which is dysgraphia. 1 out of 5 children have a learning disorder. Now, difficulties learning and using academic skills, and to be diagnosed, they need to have difficulty learning and using academic skills that persist for at least 6 months despite interventions. Their academic skills are below those expected for age or grade level and interfere with academic performance or with their ADLs. Learning difficulties begin during school-age years, but may not become fully apparent until standardized testing begins. Again, your types are your dyslexia, dyscalculia, and dysgraphia. So intellectual disabilities. There can be deficits in intellectual, social, and daily functioning. Intellectual functioning, these will show as deficits in reasoning, problem solving, planning, judgment, abstract thinking, and academic ability. Social functioning, you see impaired communication and language skills, difficulty interpreting and acting on social cues, and difficulty regulating emotions. Daily functioning, practical aspects of daily life are impacted by a deficit in managing age-appropriate activities of daily living, functioning at school or work, and performing self-care. Now, the majority of intellectual disabilities are mild, but they can be moderate, severe, or even profound. Etiology, genetic disorders such as Fragile X or Down syndrome, and environmental factors such as pre- or postnatal infections, exposure to toxin, or nutritional deficiencies can be contributing factors. Now, what are challenges? Challenges can include things like epilepsy, GERD, constipation, sensory impairments, injuries, and aspiration or choking. Approximately 10% of affected individuals are a result of problems during pregnancy or birth, and that includes things like malnutrition, chronic maternal substance abuse, and maternal infection. So, application of the nursing process. Again, assessment. Assess for developmental delays and signs of potential abuse or signs of neglect. Nursing diagnoses, you can see examples here on table 11.1 and page 177 of your book. And for your outcomes identification, you can see the bulleted points here on page 177. These are uses spoken language to make or respond to request. engages in simple social interaction and accepts assistance or feedback regarding behavior without frustration, tolerates social interaction for short periods of time without becoming disrupted or frustrated, and refrains from acting impulsively towards self or others when frustrated. Now, the implementation should be individualized but also realistic for your patient. And evaluation, this is where you identify areas of need and you maximize their family resources. So autism spectrum disorders are a group of developmental disabilities characterized by significant social, communication, and behavioral deficits. Autism spectrum disorder is a complex neurobiological and developmental disability that typically appears during a child's first 3 years of life. They can range from mild to severe with symptoms that limit or impair daily functioning, but your hallmark signs include rocking, flapping hands, and spinning. Now, children may also lack interest in others. They may have trouble showing or discussing their feelings. They may maintain poor eye contact and resist physical contact. Some children may speak very well, while others may not speak at all. Now, as far as the etiology, there is a link to specific inherited genes as well as environmental factors such as advanced parental age. Comorbidities tend to include ADHD, epilepsy, psychiatric behavioral complaints, GI disorders, and depression. Page 178 gives you the DSM-5 criteria for autism spectrum disorder. Anytime you see a DSM-5 box, you need to be familiar with it. Now, autism spectrum disorder is 4 times more common in boys than girls, and without intensive intervention, individuals with severe autism spectrum disorder may not be able to live and work independently. Often symptoms are first noticed when the infant fails to be interested in others or to be socially responsive through eye contact and facial expressions. Some children show improvement during development, but puberty can be a turning point toward either improvement or deterioration. Some individuals with autism spectrum disorder may have low IQs, yet are brilliant in specific areas. These areas include musical, visual, spatial, or intellectual abilities such as photographic memory recall or the ability to complete complex math calculations. This is a condition known as SAVANT, S-A-V-A-N-T syndrome. Now, your nursing process. Assessment, look at these guidelines on page 178 in the box. Your diagnosis is usually combined with an intellectual disability as previously mentioned. Outcome identification, you want to see improved social interaction and communication skills as well as family normalization. Implementation, early intervention is crucial to begin implementing behavior management and family support. And then evaluation. There are different levels, as you can see here, 1, 2, and 3, based off a degree of assistance and support, with level 3 requiring the most support. Educate the family on resources and determine how they are coping with stress. Now, treatment modalities, biologically, pharmacotherapy is used to improve relatedness and decrease anxiety, compulsive behaviors, as well as agitation. Second-generation antipsychotics, such as Risperdal and Abilify, have been approved to treat children with autism-associated agitation. These drugs improve irritability that is expressed in severe temper tantrums, aggression, and compulsive behavior. By reducing irritability, they may also improve relatedness. Side effects are significant and include extrapyramidal side effects, somnolence, and weight gain. SSRIs and stimulants have also been used with success. Now, your psychological therapies, the first one is applied behavior analysis, which encourages positive behavior and discourages negative behavior. Early intensive behavioral intervention is long-term and intense therapy that combines operant conditioning, so rewards and punishment, as well as applied behavioral analysis. They're the strongest evidence for improving language and cognitive skills is with the EIBI therapy. And then Early Start Denver model is one-on-one interactions that include joint play and routine activities. Overall, children with autism benefit from a reward system for their positive behavior regardless of what therapy you choose. Okay, attention deficit hyperactivity disorder, or ADHD, is characterized by inattention, hyperactivity, impulsivity being your main ones. So inattention, these children are unable to concentrate, they are easily distracted, they have a short attention span, they are unable to follow directions, and they have difficulty with organization. For the hyperactivity, they are unable to sit still, they fidget, and they have excessive physical movement, talking, or they interrupt. And then impulsivity, they act without thinking, with a lack of regard for the consequences and no sense of danger. Now, etiology, there is a strong evidence for genetics, but also environmental factors such as low birth weight and prenatal exposure to alcohol and tobacco. Comorbidities, learning disabilities is the most common, but also epilepsy, oppositional defiant disorder, and conduct disorder. In adolescents and adults, you may see substance use disorders, sleep disorders, anxiety disorders, and somatic conditions. The behavior and symptoms associated with ADHD can include hyperactivity and impulsivity. Peer relationships are strained due to difficulty taking turns, poor social boundaries, intrusive behaviors, and interrupting others. Those with the inattentive type of ADHD may exhibit high degrees of distractibility and disorganization. They may be unable to complete challenging or tedious tasks, become easily bored, lose things frequently, or require frequent prompts to complete their task. Now, the nursing process. Assessment. Determine their level of physical activity, attention span, talkativeness, social skills, comorbidities, and if symptoms are present at home and school. And then on page 181, you have your other assessment guidelines here. For your nursing diagnosis, if you actually, let me find them. Table 11.1 on page 177 gives you your nursing diagnoses. Let's come on back down here. Okay. And then outcome identification on page 181. Outcomes appropriate for the child with ADHD target hyperactivity, impulse self-control, freedom from injury, improved social relationships, the development of self-identity and self-esteem, positive coping skills, and family functioning. Now, implementation, you need to recognize ineffective coping mechanisms and help them recognize it as well. And teach them techniques to modify behavior, and they may also need family therapy. On page 182, box 11.3 gives you a variety of techniques to manage disruptive behavior. And then evaluation. Evaluation, the focus is on the severity and pattern of behaviors, and long-term planning and goals will be important here. Your treatment modalities. Pharmacotherapy. There are medications that will increase attention span and decrease any aggressiveness. The goal of pharmacotherapy is to improve the child's hyperactivity, aggression, and play. Now, these children are typically treated with stimulants such as Ritalin and Adderall, and can also use non-stimulants such as Strattera. You have alpha-2 adrenergic agonists such as clonidine, And those are also FDA approved for ADHD. On page 183, table 11.2 are the FDA approved drugs for ADHD. Now, if you're giving a child something like Ritalin, which would be methylphenidate, you do not want to give it late in the day because it is a stimulant. And you need to keep an eye on the child's weight because this medication is a stimulant and it may suppress their appetite. Teach about common side effects such as dry mouth, restlessness, insomnia, weight loss, but also tachycardia. And teach them to avoid caffeine due to caffeine will increase the medication stimulating effects and it can actually lead to irritability. And then you have Strattera. You need to educate a child on Strattera that the child needs to increase their caloric intake when they're on this medication. So they need to increase their calories. And teach that insomnia is a very common adverse effect of Strattera, so they need to take this medication in the morning. Now, psychological therapies. Parent training is the first line of treatment in children under the age of 6 before you start medication. We start with parent training. And then that cognitive behavioral therapy, CBT, changes behaviors internally and you work with the parents to improve coping and stress. And you can find some of these in box 11.3. Again, techniques for managing disruptive behaviors. Now Victor, he's 5 years old, will soon be starting kindergarten and his dad, a single father, is very anxious. I have no idea how Victor is going to make it in school. He's completely out of control. I have trouble getting him to calm down. When he was little, I was kind of proud of how active he was, running from one thing to the next. I took it as a sign of curiosity and intelligence. But as he's gotten older, he's still like that. Only he can't calm down and sit still for anything like other kids his age. Something's got to change. Victor has now started kindergarten and is exhibiting the same problems his father expressed frustrations with earlier. His hyperactivity in particular, and his inability to listen when his dad tries to correct or slow him down. What would be included in Victor's assessment? You should assess the level of physical activity, attention span, talkativeness, social skills, and any comorbidities. Remember that these must be present in 2 settings, at home and in school. Now, Victor is diagnosed with ADHD after being assessed both at home and at school. To begin with, a psychiatric mental health nurse works with Victor to help him change his pattern of misconduct, working with Victor's father as well to help him develop internal controls and to help them both improve coping and support. Victor expresses delight over a few cognitive behavioral therapy games aimed at developing problem-solving skills and conflict resolution. Use of medications are discussed as a possibility. Which statement demonstrates that Victor's dad understands the diagnosis of ADHD? B. Victor's performance will improve in a structured setting that provides rewards for appropriate behavior.